Good afternoon, everyone, and welcome to the Health and Adult Social Care Scrutiny panel for Thursday, 18th of February. We are live on webcast, and members of the public can listen into the meeting, which will be available on YouTube after the meeting. I'm Councillor Habiban Zaman. I'm the chair of the panel, and if members could please introduce themselves. If we start with Dave.
Hi, I'm Dave Rigby. I'm a co-optee.
Leslie. Leslie.
You're on mute, Leslie.
Sorry, Leslie Warner, Councillor Combe Valley Ward.
Alison.
Alison, you're on mute.
Sorry, I'm Alison Monroe, and I'm a local councillor, Kirklees councillor. Thank you.
Bill.
Yes, Councillor Bill Armicker, Burton Ward.
Vivian.
Councillor Vivian Lees Hamilton, Murfield Ward, and panel member.
Afak.
Councillor Afak Butt, Councillor for Hetman White Ward.
Could you please put your camera on? Lynn.
Good afternoon, everyone. Lynn Keedy, and I'm a co-op team member of the panel.
Okay, and we also have Liz. Liz, would you like to introduce yourself?
Hello, Liz May, Chair of Overview and Scrutiny. Thank you.
Okay, thank you. We will move on to the agenda, minutes of the previous meeting. Can we have somebody to move them as a true record? Okay, thank you. Any members of the panel who may have an interest to declare?
No, thank you.
Sorry, who was that? Leslie.
Oh, I wasn't speaking then, but yeah, I'm a governor of the Calderdale and Huddersfield NHS Trust.
Anybody else? Okay, we move on to item 3, which is admissions of the public. We have no admissions today. Item 4 is deputations and petitions. Again, we have no deputations and petitions for this meeting. We have item 5, which is public question time. We have, sorry, Martin, have you put your hand up?
It's for this item, please, Chair. Yes, public questions.
Public question time. Okay. Okay, so for public question time, we have Councillor Martin Bolt who would like to ask a question.
Thank you very much, Chair. Yes, I'd like to bring something to the attention of the panel for consideration or for a response. They may have already considered it. The situation with regards to GP practice boundaries. There seems to be no coordination between provision of GP practice areas. This was brought home to me when we're having 166 new homes built on Leeds Road, Murfield, and probably half or 2/3 are outside of the practice boundary of Murfield Health Centre, even though they're within the Murfield Ward and Murfield Parish Council area. So in looking at this, and the GP practice maps are not easy to find, I found that these future Murfield residents, some are already moving in, although they can't go to the Murfield Health Centre, have been told that their practices are Birstall, Dewsbury, Littletown and places like that, which are much further away than Murfield. And it means that obviously there's no bus service goes past there, so if they don't have a car, getting to the GP is difficult. From a professional perspective, if GPs are having to travel much further to do home visits, it seems to be inefficient for them. So it's that situation that the CCGs don't look to have this overarching scrutiny and making sure that we're served The other thing, talking to one of the partners in Murfield Health Centre, is the concern that he raised that with new housing in areas, and we'll see this throughout the area with the local plan, our GPs get no contribution from the planning process. Next week, those fortunate enough to sit on strategic planning will hear 2 applications totalling 130 new homes within the immediate practice area of Murfield Health Centre. So 130 new homes, goodness knows the demographics within that. The other thing that colleagues may not be aware of is for some time we are supposed to had some choice. You could elect to go to a GP practice. If you're outside the area, the people you appeal to are the same GPs who's just told you that you're outside their practice boundary. So there isn't, again, any arbitration or oversight. I appreciate it may not be something that's cropped up before, but having seen this with these 166 houses that are being built as we speak in Murfield, I think around the district it's an issue which we do need to have an oversight of. Thank you, Chair.
Thank you, Councillor Bolt. I'm not sure whether we have someone who can answer that question on the panel at the moment. Would it be Helen, or could we get back to you with an answer on that?
Good afternoon, Councillor Zaman. I'm not actually employed by the NHS anymore. I retired at Christmas. So I would suggest that we can make contact with colleagues at the CCG and ask for a written report to respond to that specific question about how this is taken into consideration.
Okay, Richard, are you wanting to come in there, please?
I was just going to make a similar offer that I could pick that up with the CCGs.
Thank you. Thank you. Councillor Bolt, we'll get back to you on that question.
Thank you, Chair. Much appreciated.
Thank you. Thank you for that. Okay, we move on to the next item, which is the independent analysis of the future size and shape of the older persons care home market.
So that's over to me then. Thank you, Councillor Saman.
So who's going first? Okay, Helen.
Yes, I'll lead it off. I'm sure Richard and colleagues will probably want to come in and there'll be questions, I'm sure, at the end. I'll just give a very brief introduction and overview to today's report, which includes the background to the commissioning of the care home market development and sustainability work, the early findings from the work to date, and the plans for the next steps. So just some background. Over the last few years, we've seen a number of changes in how we support people to live well in their own homes in Kirklees. This includes the priorities in the health and wellbeing plan, especially around frailty and end-of-life care, and our social care vision for Kirklees. We're also working in partnership in the development and the delivery of national policy, including the NHS long-term plan. We've also seen the development of services in the community over the last few years, which has included the increase in provision of domiciliary care and the move away from time and task to supportive individuals in their own homes to more an outcomes-focused care plan. We've also responded to people's needs with additional reablement services. And we've also a national pilot in Kirklees for something called the Urgent Community Response, is where providers have come together to support people to prevent hospital admission where that's appropriate and safe. We've also got the growing use of technology, including telehealth and telemedicine, and the increasing use of equipment. Also across Kirklees, we've got our development of our specialist accommodation strategy, which includes additions to our extra care housing, which will be coming on stream shortly, looking at how we can do retirement housing, and also reviewing our sheltered accommodation. Also, national research has shown that people want to be supported to live in their own homes for longer, as long as they can, and it is safe to do so. And over the last 15 to 20 years, research has shown that there's been an improvement in the health of older people. So that is a less demand again for care home places. So as background to all these strategy and policy changes, it was recognised that this would lead to the changes in the needs and the demands for the care home places in Kirklees, especially around the older care market. This change is happening nationally, regionally and locally. And in Kirklees, it had started well before the pandemic, but obviously the last year has sort of expedited this rapid change, with our care home sector facing significant challenges in relation to reduced admissions, the increase in death rate, especially in people over 75 and 85, the reduced occupancy and an increase in their business costs. In relation to the report, we now have a draft of the report, which we have shared with our care home providers. And in there, it contains a number of detailed chapters, which includes the review of the current market, recognising we have different segments of the market in Kirklees, especially relating to older people, learning disability and mental health, the demographics and the future plans around changing demographics, population and a demand summary, and also a view of what the market should start to look like over the next 1, 3, 5 and 10 years. It also reviews the options about the interventions that we as a council should play in the development and delivery of the care home sector, with minimal, medium and high level interventions to be identified. And it's recognised we may need different responses for those different segments of the market. Under section 5 of the report, it identifies some early findings, and I'll just bring out a couple of those to you now. One is the fact that we'll probably need to re-baseline the bed base to achieve those desired occupancy levels, especially in the older people sector, and that the predicted demand for care homes for people with more complex needs and support will mean that we'll have a shorter period of time in the home. This again, for older people, will have a significant effect on the sector, so that there will be an impact on the skills for staff training and development, the buildings that will need to be utilised to provide that care, and also the impact on care management. So the next steps we have around the report are that we will continue to meet with the Care Home Association, which is developing in Kirklees. We have a regular care home provider forum. We're meeting again next week. We will go through the detail of the report, and we have a workshop planned for, I think it's the 19th of March, to go through the document in detail, get it to a final stage of a report, and also look with colleagues around the table about how we will start to develop the implementation plan to deliver on the report. Richard, I don't know whether you would like to add anything, or whether it's over to questions.
I think I'll reflect, there's a complexity to this, which is about making sure, as Helen says, we see the broadest offer to people to help them to live independently. So this ties into the work around housing development, so extra care, but much broader than that, the sorts of kind of lifetime home approaches that will be important. And again, that this isn't an issue which is Kirklees specific. This is an issue which is the case for a number of local authorities.
Habiban, you're on mute.
Sorry. Thank you, Richard, for that. Dave, would you like to ask your first question, please?
Yes, thanks. Just arises out of some of the key findings. Given that it's anticipated there'll be a move away from care home provision, I wondered whether, if you're looking at the market for care homes, it would make sense to, at the same time, be looking at the market for domiciliary care, because it looks like from those key findings that the two need to go hand in hand. So is that something that's planned?
We've already well on the way with our domiciliary care provision. We've seen a vast rise in the number of hours per week that is now provided in Kirklees. This has been an upward trend even before COVID. So I think the hours have increased from something like 8,000 a week to nearly 15,000 per week of hours of domiciliary care into people's own homes, and we see that trend continuing, especially during the last year. So we are working together. Some of our care home providers do also provide domiciliary care. It is a small number, but they're also involved in that as well.
Yeah, I was also thinking in terms of the market looking forward. If there's a growth in demand, is it anticipated there'll be a growth in supply, or does that need to be stimulated in some way?
Yes, we did stimulate the market about 18 months ago when we reviewed the actual cost basis for domiciliary care provision. And again, it's recognised if there are more people with more complex needs staying at home, we need to work with the sector to ensure that their staff have also got the adequate training and development to be able to meet the needs of the people with more complex needs at home as well. So we are working jointly with them to do that.
Okay, thank you. And I just wondered, and what would the timescale be, perhaps, for the panel to consider the findings of the final report?
I would suggest it probably be about May, June time, so we'll have a fully developed implementation plan then. That's not to say the work on the implementation won't start, because we recognise there's some urgent demands that need to be taking place. But we will, I think it would be probably May, June time before we could bring that back to you, if that would be okay.
Thank you. Richard, are you wanting to respond to Dave?
Yes, perhaps just add, we've got an organisation that we work with, part of the council, called Into Care, that supports recruitment into the care sector, and that's supported the recruitment of about 1,000 people into the care sector, including 400 personal assistants. So these are people who are employed outside of a normal home care agency, but often on a one-to-one basis by people who need support in their own homes. We've also been doing some work to stimulate micro enterprises. So this is rather than a conventional home care agency. People who are going to either be self-employed or will employ just a very small number of people to work in more niche areas. So that might be with some particular BAME communities, it might be in some of our more rural areas. So we're absolutely not just increasing that supply through the conventional home care arrangements, as Helen has talked about, but actually looking at some alternative models of delivery as well.
Okay, thank you.
Thank you. Councillor Bill Armour, would you like to ask your question? Bill, we can't hear you. We'll come back to Bill. Councillor Allison, would you like to ask your question?
Okay, sorry. Yes, my question's actually just changed a bit since the one I discussed earlier, because I'd misread the figures. But so it's around there are some fluctuations in the CQC ratings, which I've picked up on. But generally, they have the quality of care has actually improved, which is in contrary to what I said earlier. But my question is, if we're going to have more people being dealt with in the community at home, and there's going to be more domiciliary care, surely this is going to impact on the CQC ratings, on the care home sector itself, and that could be a detrimental impact. So how would that be addressed, or how might that be addressed?
Richard, do you want to respond to?
I can start us off, yes. So I think what we're seeing is a shift in the balance of care provision away from care homes, as Helen said, into that domiciliary sector. It doesn't mean that we will not need care homes and nursing homes, but they are likely to support fewer people, but more likely people with more complex needs and for a shorter period of time. So if we think back, a decade and a half, 2 decades ago, care homes were retirement homes, and people retired people moved into them at a relatively young age, but were very active in, and be out and about in their community. That's of course not the case anymore. So I think in terms of detrimental impact, I think it'll more be a shift in the market. What it will need is, we may need fewer providers, and they will need to adapt and be providing, I think, a slightly different offer. And that's the process that, since this report was there to start to stimulate that debate and the work with providers around how that's managed. And there may be some providers who, have a building that actually they choose to use in a different sort of way for perhaps, supported housing with support rather than a care home provision. So I don't know that it'll necessarily have a detriment. If we manage the transitions, it shouldn't have a detrimental impact. I think this is about enabling organised providers to adapt their model of delivery to meet what will be the demand over the coming years.
Thank
you very much, Richard. Thank you.
Okay, Lynn.
Thank you, Chair. I just want to raise a couple of questions, if I may, please. On page 5 of the report, at point number 8, the vision for adult social care. I think I've mentioned at a previous meeting that I've actually seen the document from Kirklees titled Our 5-Year Vision for Adult Social Care in Kirklees 2020 to 2024. I'm not sure whether that's actually been signed off as a final draft yet, because I saw it at an evaluation stage. But I was asking my panel colleagues earlier before we started the formal meeting whether they'd actually had sight of that document, and it appears not. And so I was wondering whether I could ask if a copy of it could be sent to the panel for circulation, please. And my second question relates to page 7 of the report, point number 12, next steps and timelines. And in the second paragraph where it says, as final reports are produced by Cordis Bright, we will develop a joint delivery plan, etc. I just want to ask that in due course if that plan could be routinely copied to the panel, please. Thank you.
So I'll respond and say yes, it's to both questions. We will certainly circulate the vision. And I think we've just discussed that we'll bring the report and implementation plan back probably into a May or June meeting, if that's okay.
That's fine, thank you. I wasn't sure if it was the same plan, so I thought I'd just bring it in just to make sure. Thank you very much.
Thank you.
Is there any further questions, Leslie?
Yes, thank you. Just a number of small questions, really. One of the first ones was at the beginning, on our page 11, the rationale behind the research. I just want a clarification. I see that we went for an external company to deal with because we said it would bring a rigour to the work, but we worked in partnership with Rotherham Council. So I just had a question about, were we not able to do it in-house? I mean, it's just this increasing concern that more is going out to the, to the private sector, and whether, I'm sure it's thorough research, but I just have a concern about that. And at the same time, linked to this question is you mention less demand. But as against that, and I understand that the market is changing, as against that, people are living a lot longer. And, it kind of concerns me that we could be in a position where far more people are reaching, 90, even 100 as they are now, and it's not possible for them to be at home. And where are they going to go? Because at the same time as this, we all know, many of us of my age, wonder, the need for convalescence home. Those people from hospital who aren't well enough to go back into the care home, where do they go? So I have questions about that. And I've also got a question linked to that about the whole staffing issue, which has long been an issue. And in the light of Brexit, I suspect, given that, large proportion of people from particularly Eastern Europe worked in the care sector, how that's going to impact on all that. So I mean, they're not really linked, but they're the same issue about how it's going to survive, really.
I'll try and take them. If I don't get them all, please remind me, Councillor Warner. So with the Brexit discussion, we've had detailed discussions with the Care Home Forum and care home providers to encourage and support staff and to ensure they've got all the contact points for the support that's been offered through the council and in Kirklees to ensure people are registering as part of that process. We also did a survey, I think it was last year, in readiness for Brexit to identify the numbers of staff that were currently working in care homes, and if the worst did happen and they did return to their country of origin, what impact that would have. So that was worked through with the care home providers, and they've developed business continuity plans if they felt that was required, if it was going to impact their particular home. In relation to the demographic trends and changes, yes, we know that, we're going to have more older people, we're having more people living longer, but part of the research has shown that people are living healthier lives for longer. and that when they do require, they will require that more complex care and need, and it's recognised that we do need a workforce development and training strategy as well as a recruitment strategy to ensure that those longer term plans are in place, and that will be part of the detail of the implementation plan, how we can work with the sector to develop those proposals and to support them in ensuring that training and development is in place for staff. I think I may have missed one of your other questions, so apologies.
It was just to do with, you know, what in fact is in place at the moment with those people who have to leave hospital, can't go home, you know, can't yet go into a care home. You know, I would just, you know, nothing replaced convalescent homes, did it?
Yeah, so we have a number of things. We've got our intermediate care provision within the council provisions at 2 homes. So they help with what we call some step down provision to ensure people receive that rehabilitation and additional support before a longer term plan is put in place. And also during COVID, we've developed the discharge to assess pathways. There are 4 levels of pathways that are in place now nationally. And some of that is about we obtain beds from within the independent sector to support those discharge to assess pathways, so people are assessed more appropriately in a care home environment before a longer term plan's put in place. And we're finding that a high percentage of those individuals are still returning to their own homes with a care package, and obviously some go on to a longer term placement. Richard, do you want to add?
I was just going to reflect, there's the risk that we see this report as about being something new. There's already at least a 5-year trend of decreasing numbers of people moving into residential and nursing homes. So I think what we're saying is there's been a trend. COVID has accelerated that in the short term, and what we want, the piece of work really was to try and identify, is that going to, you know, what will be the position over the next 5 years? Will that trend be reversed at all, and if so, to what extent? But this isn't something new. Fewer people moving into care homes is a well-established trend, as I say, over 5 years.
Okay, thank you.
Thank you, Richard. I'm not sure whether we've got Bill back. Is there anybody else that has a question? Okay, I can't see Bill on the call, so we'll move on. So thank you for that contribution to that agenda item. In terms of the recommendations, I would like to recommend that the panel considers the information provided and determines that we get the 5-year vision 2020 to 2024, and also minutes of the West Yorkshire Partnership are shared with the panel, as well as the final report that's to be produced by Cordis Wright. Okay, and if we can move on to the next agenda item. Item 7, which is the COVID update, and we have Carol McKenna and Emily. Harry Harris, who is it that's going to start?
If it's all right with you, Councillor Zaman, Carol's going to go first to give a brief update on the vaccination programme. Then Jane O'Donnell's going to join and pick up the update around the testing specific issues, and then I'm going to give you a general overview of the figures and the position in Kirklees. That's slightly out of what might be a logical order, but it fits with the demands on Jane's diary. So if that's all right with you, that we take it in that order.
That's absolutely fine.
Yeah. Brilliant, thank you. In that case, Carol, over to you.
All right, sorry, Emily, you caught me on the hop there. I thought you were going first because I was going in political order. But never mind.
I'm so sorry. I'm so sorry.
It's fine. We can do vaccine first. So where to start? As people probably know, we've first of all, can I just say that my colleague from CCG, Lindsay Greenhouse, is also on the call. Lindsay's our head of medicines management, so on technical questions around the vaccine, she's much better qualified than I am to maybe pick up some of those issues. So maybe if I can just start by saying we've been vaccinating Kirklees residents now since the middle of December. And as of the beginning of this week, we were in a position where all residents in the top 4 priority cohorts had been offered a vaccine. As you will know, a national message went out, I think it was the end of last week, that anyone over 70 who hadn't actually been vaccinated and wished to be should actually contact their GP, just in case anyone had sort of fallen through the net there. And obviously that is underway now. We feel we're in a really good place in terms of the vaccine rollout. There is a press release that you'll see today probably that's come out from West Yorkshire to indicate that in West Yorkshire we have now vaccinated just over 500,000 residents, which is around a quarter of the West Yorkshire adult population, and that's fantastic news. So real progress. Within Kirklees, we've got the vaccine being delivered from a variety of sites. So the initial sites that went live were organised by our primary care networks, and we have 5 PCN sites in total operating across Kirklees, 2 in North Kirklees and 3 in Huddersfield. And they continue to deliver vaccines on a very regular basis through the weekend and at weekends as well. That's also been supplemented more recently by the opening of the community vaccination centre at the John Smith Stadium, which opened in late January. And in addition, we also have 3 community pharmacies providing the vaccine, Boots in Huddersfield, the pharmacy in Hornley and the pharmacy in Bristol. So there are those options available as well that people can book into. So I think actually I might just leave it there by way of introductions, because I'm sure people will have questions about it. So is that okay if I just pause there?
Yes, that's fine. Do you want to go on to the questions now, Carol? And then
whichever works for you, or if you want to hear everyone and then pick things up right at the end of all the updates, I'm happy to do that.
Well, David and Atak have already got their hands up, so we will go to David.
Okay, thank you. Thanks for the update, Carol. Yeah, it's great to see how the vaccination programmes are going. I've just got a question about availability at a very local level. I see the list of places where vaccinations are available. My concern is, I understand nationally there's quite a large number of older people who have not yet responded to the call for a vaccine. And my concern is for those older people who don't have a car. So if you don't have a car, then to get to one of the existing centres, you're probably going to have to use public transport. And a lot of people won't want to use public transport at the moment. They won't want to use a taxi, and they won't want to have a lift if one is offered. So it's really taking the example of where I live in the Colne Valley. I think the nearest centre is at least 5 miles away. So if you don't have a car, how do you access something local easily and safely?
Yeah. So we did identify this as an issue a little while back, and colleagues in the PCNs have been working really closely with council colleagues to enable some voluntary sector providers. There's one in Denbydale, for example, but there are others, to be able to support vulnerable individuals to get to appointments. I appreciate it still means getting a lift, obviously, from someone, but we have got arrangements in place where practices identified that they have an individual who's got no means of getting to the vaccination centre. Obviously, if someone is housebound, then the service goes to them. But there is additional community support in place now to help people get to the centres.
Okay, thank you.
Thank you. Councillor Rafaq, do you want to ask your question?
Thank you, Chair. I was typing the question into the chat box as you requested. However, it was taking too long, and it's probably quicker to ask it myself.
That's not for you. That was for Councillor Bill Armour, because.
Oh, okay. problem. So thank you very much, and thank you for what you've said so far. And you know, it is an absolute fantastic achievement so far, nationally and locally as well. You know, about the vaccination programme. So thank you to everybody that's been involved, and yourselves and everybody in the front line and everybody at the back that makes that happen. We're truly grateful. My question really is about, so I'm one of the councillors for Hetton Dwight Ward, and somebody had put on there that they'd gone to the Al Hikma Centre in Batley and they'd gone for their vaccine, and he said to think of the demographics of the area around Batley and around those areas. He said the vast majority, bar 2 or 3 people, were white. Now, he said, why is that? Why are BAME people not coming together to have the vaccine? And it's something that my fellow councillors will relate to as well, is that we're trying to do as much as we can with volunteer groups and sort of community groups, the mosques, etc., to get those messages out. But is there any plan sort of centrally from yourselves to maybe reach out in different languages, or maybe to sort of connect with people in their language almost, to kind of say, look, it is important. You are most at risk. BAME people, you know, are at risk with multi-generation families living together, etc. So is there any work kind of being looked at to try and reach out to them, to kind of support our work that we're doing on the ground as well, which of course is a little bit inhibited because we can't have that face-to-face contact.
I wonder if I could ask a couple of
do you want me to pick that one up, Carol?
Absolutely, but equally, I'm conscious that Siobhan's on the call now as well, and also Lindsay's been actually doing quite a bit of mutual aid out in some of the sites, so might even just be able to get a sense of what she's observing with population groups. Okay. But you kick off.
So thank you, and Lindsay, please feel free to join in from the sidelines. So in the local authority, Councillor, but one of the things that we're doing is taking an equality impact assessment, so that we can assess the data that's flowing through from our colleagues in the NHS to ensure that the vaccine is being offered equitably across our populations, but also that it's being taken up equitably across our populations. We know that there are particular groups who are more vaccine hesitant than others, so need some additional support in order to take the vaccine. I think the really, really good news is, even in those groups where the uptake has not been as high as we might want it to be, it's still been really good. It's not good enough, and we need to make good progress. But there is no group where we are actively, very, very worried because nobody in that group is taking it. So I think that's the good news story. And I think we need to talk about the vaccine in very positive terms, because part of what we're doing is creating confidence and creating that social norm that people like you are having the vaccine. And we've absolutely been blown away by the level of uptake that there has been. Having said that, we are aware that there are particular communities where that hesitancy is greater. And I'm using the term hesitancy very deliberately, because it's not that people have necessarily said, no, I am not having the vaccine. It's just that they perhaps need a little bit more time, a little bit more support to access the vaccine, as you suggest, things like materials in their own language. So we've been doing a lot of engagement with things like local radio stations to get the messages out there. There have been a lot of community-based webinars, often within the faith communities, but not always, to give those very positive, affirming vaccination messages from people that people within those communities already trust. Because that's key to this, is the trust that people have in taking the vaccine. So there's lots of comms work going on. There's lots of work within the community groups that are linking into the local authority. And what we are seeing is, over time, those groups where the hesitancy has been greater, those numbers are increasing. So it really is that people just need that little bit longer and that little bit of additional assurance. But generally, the uptake rate has been incredible. Lindsay, I don't know if you'd add anything to that.
Just to echo, really, Emily, I know when I've been out on various sites, people have been accessing it from across all communities. the reception from patients and the public coming in has been unbelievable. So positive, quite excited, to be honest, want to be out of the house. But also just that interaction, and actually there is hope for people, as a way out of this. So I think, we're right, we are looking at expanding some of the work and how we can get to some of the communities who may be a little bit more hesitant, but generally from what I've seen, the uptake has been extremely good across all communities. Really positive.
Thank you.
I'm in priority group 6 and I'm beside myself with the thought of a trip out. I'm so excited.
Thank you.
Thank you.
Councillor Munro, would you like to ask your question?
Thank you. I've actually got 2 questions, but I'll just get my first one is in relation to the follow-up, the booster vaccine. So for people in the first 4 cohorts who've received their vaccine, the first vaccination, but not the booster because they're having to wait 12 weeks, can you tell me that they will definitely receive the same brand of vaccine that they or I know the government were doing some testing on this to see if they could mix vaccines up, and which sounded horrendous to me and didn't really particularly instill me with any confidence at all. And if it was me, I'd be very worried about being given one brand of vaccine and then a booster 12 weeks later by a different brand. So could you just explain what's happening with that, please? Thank you.
Do you want to do this, Lindsay? This is your territory.
Yeah.
Yes, that's fine, thank you. So we have been assured nationally that the supplies have been allocated based on reciprocal deliveries for the second dose. So like I say, we have been assured nationally that people who have received a certain vaccine for their first dose will in fact receive the same vaccine for their second dose. And we're due in Kirklees to start the second doses, I think roughly about the 8th of March. So we have been given that assurance nationally.
All right, thank you very much. And my second question is really around doctors, because I understand that almost 50% of doctors have actually declined to have the vaccine, and it doesn't particularly instill confidence, in the vaccine. And additionally, if those doctors who decline to have the vaccine then succumb and unfortunately contract COVID, then their practices would have to be closed down, and that would affect everybody in the area. So, is anything being done to address that issue?
I'm not familiar with that figure. I don't know where that's come from, Councillor Munro.
It's just some research I've seen online.
Right, I haven't seen that. I'm not aware of it.
Okay.
I know we're doing everything we can to encourage take-up amongst frontline health and care staff. We've certainly got a number of our own GPs who are, demonstrating that they've had the vaccine and doing everything we can to encourage our communities to do so. But I'm not familiar with that statistic, to be honest. I need to have a look into that.
Right. Okay. All right. Thank you very much.
I'd like to ask a question just as a follow-up on Alison Munro's question. There was a lower take-up of the flu vaccination. So are we still focusing on that alongside the COVID one, or are we just?
Yeah, funnily enough, we had exactly this conversation this morning, Lindsay, didn't we? Noting the difference between the take-up rates for the COVID vaccination compared with what's happened with flu. But we have remained focused on the flu uptake throughout the winter. So it's not that attention has gone away from that and into the COVID vaccination. We have continued to push that wherever possible. But you are right, there is a differential in the take-up rates, and that might be about how people perceive the risk, or I don't know, but you're right. There has been higher take-up rates of the COVID vaccine.
Okay. Can I bring in Judy in?
Thank you, Chair. And actually, my question just follows on from yours, really, because it was to do with the information that we've been given about the flu immunisation programme. And I haven't got the figures for the previous year, but I just wondered if the flu vaccination uptake was lower this time around than it was in previous years. And just a few general points really, such as when you look at the percentage of people who had a flu vaccination compared to the vaccination target, I just wondered if we knew whether the shortfall was due to the vaccination being declined or whether there were other reasons. And going forward in time, when the immediacy of the COVID-19 pandemic has passed a bit, and perhaps people might not be as focused on annual vaccinations for COVID-19 if that's what we have to have. Is there some learning for the future that we can take from, you know, the flu vaccination programme and maybe come up with some kind of related action plan for both flu and potentially COVID-19 vaccinations going forward? You know, are we perhaps finding out where people decline the vaccination, why that is? And I appreciate, of course, that we can't put pressure on people, but it's asking the right questions, isn't it? And just trying to get to the bottom of what's led to us being quite some way below the actual vaccination targets. Thank you very much.
Wonder, Chair, if I can see Emily's asked if Jane can do her update now. Jane's also been quite close to the work of the Flu Programme Board, so perhaps, Jane, if there's any observations you've got on any of the flu vac stuff as part of your update, okay?
Yeah, that's
in
fine.
fact, Jane has a slide on that very topic. So if you just bear with me one moment while I share my screen, and then Jane can do her thing.
Yeah, I'll answer, to be honest, Emily. I'll go to the flu vaccine question to start with, because if we look at the flu vaccine uptake data, it's actually higher than it has been in previous years. And obviously, one of the reasons why individuals tend to refuse the flu vaccine, it's particularly in the clinical at-risk groups who are under the age of 65, because they don't see themselves as clinically at risk against flu. Obviously, they take the regular medication, so they don't see the risk. You know, I'm not going to get flu, so it's that perception. So you know, a lot of work does happen with sort of individuals within these clinical at-risk groups, but as we've said before, it's not a mandated. We don't mandate vaccines. We explain risk and benefits. People are given wide opportunities to either get it at the GP or community pharmacy. So there's many options where people can get it, and particularly people who are working. So those tend to be the reasons why we tend to see a lower uptake in the under 65s. Our over 65 population tend to be always the ones what are there as soon as vaccine is available to give the flu vaccine. So hopefully that gives you some assurance that work does continue on trying to improve flu vaccine uptake.
Yes, thank you.
So if I, sorry, Emily.
I was just going to say, Councillor Zaman, if you're okay that Jane goes through her slides and then we'll pop back into the conversation about the vaccinations. Is that all right?
And then Jane can leave. Yeah.
Brilliant. Thank you ever so much. Right, Jane, you tell me when you want your next slide.
Right, thank you. So obviously we want to give you a little bit of an update about community testing. So we obviously now have got our 4 community testing sites, which from the lockdown in January have now been repurposed for critical workers who can't work from home. So people who live or work in Kirklees who are asymptomatic and can go and get a lateral flow test at one of the 4 sites. This is obviously seen as an additional control measure as part of COVID Secure. Obviously now a confirmatory PCR test is not required. This has been temporarily suspended nationally on the 27th of January for people who go to community testing sites. This is because the amount of COVID-19 virus that is circulating in the community remains high. This will be reviewed, and as community rates go down, we do expect that will be put back in place, that the PCR test is required. Next slide, please, Emily. Thank you. So Previously, we've discussed about what was the Director of Public Health target testing. This has now merged into part of the community testing programme, but we still obviously look at critical support workers and those work with vulnerable communities. We're also working with businesses which are critical. So some of our targeted testing now has gone to help with fire and rescue services, the public transport, so a Riva bus company. We work with some of the food industries as well. So we've got quite large employees where they're actually doing targeted testing as an additional control measure. Next, please, Emily. Also with schools, the MHRA has licensed self-testing at home for primary school staff, but this does mean that they actually have to have a confirmatory PCR test. That hasn't been relaxed with primary schools, because what we want to ensure is that that test is actually accurate. So obviously if they get a positive PCR test, they continue to isolate for those 10 days and obviously identify their contacts. Secondary schools and higher education, staff are tested twice weekly, and students will be tested on returning to school, 2 tests 3 to 5 days apart. Again, must stress that these are not mandated, they are encouraged tests, so people cannot opt in via obviously it's consent is given by the parents for children, and obviously staff obviously give their consent to participate in the programme. As part of what was the DPH offer, we're working with Locala to do an assisted swabbing for special schools, particularly for obviously for the pupils, because obviously with complex health needs, individuals cannot self-swab, and teachers would probably not feel very confident. So as part of our offer, we're working with special schools to offer that facility now. Next, please, Emily. So care home residents, we've discussed this previously about we wanted to ensure that care home residents who are discharged from hospital are discharged into sort of designated settings. So most people discharged to a care home will receive a COVID PCR test within the 48 hours prior to discharge. The negative test should be communicated to the care home manager as part of that discharge information. But as we know, some people remain positive, are still in that positive stage when they actually are well enough to go back to the care home. So if they're being transferred back to that designated care home, they would continue to do their period of isolation. And that isolation for care home residents and staff is for 14 days, not the 10 days what the general public do. So obviously, care home testing is a different approach to other testing. So if somebody tests positive after contracting COVID-19, we wouldn't start doing routine testing for 90 days. This is because the virus can remain in the respiratory tract, so get a false positive. That individual is not infectious, so this is why we say we don't retest for 90 days. It's just important that they've completed their 14-day isolation and obviously feel well and don't have a temperature for 48 hours up to their isolation period to end. Next one, please, Emily. Oh, I think that's been covered.
Carol's done that
one. And as I say, we've looked at, we've mentioned about the flu immunisation uptake. So as you can see, for the over 65s, we're actually at 81.5%, which the actual national target is 75. So, and then obviously we do see the percentages go down, but as I say, we tend to see people perceive themselves not at risk, but these are the percentage uptake is greater than it has been in previous years. Yeah. Thank you.
So that was the end of Jane's presentation. I've got some more slides that I'll show you for a general data update. I'm so sorry that this is all out of order, but it's just trying to make the most of people's busy diaries. So, sorry.
Are we able to ask any questions from Jane, or does Jane need to leave?
No, I'm quite happy. I've got a few more minutes.
No, I think Jane got a few more minutes, haven't you?
Yeah.
Okay, well, if there's any panel questions, panel members that would like to pose a question to Jane. Dave?
Right, thank you. Yeah, I think one of the slides mentioned for anyone testing positive, they were discharged to a designated care setting rather than the care home. Could you just clarify what that means?
That tends to be that the allocated beds for COVID positive patients. So it may be a care home or a floor of a care home what does take patients what are known to be COVID positive.
Right, and how is that process working in practice?
I do know that we have some discharge to care beds where our patients do go. If they don't go back to their care home, if their care home obviously feels that they can't take that patient at that time. So I do know that it is working across Kirklees.
Okay, and I think it's on the same slide. It mentioned that most people discharged will be tested. I just wondered why that's not all people.
If you've already tested positive, we wouldn't retest. So otherwise people will be tested on discharge from hospital.
Okay, thank you.
Thank you. Lynn, I noticed you had your hand up. I'm not sure whether your question is for Jane or it's still up from previous discussion.
No, it is a new question, please.
Okay.
It's just for a bit of clarification. On the slide about care home testing update, I just wanted to clarify the bottom line where it says and have a normal immune response, and I just wondered what that meant in practical terms, please.
Right. I suppose it's when we've been discussing about people who are shielding. So normally, obviously, if you've recovered and you're termed healthy, then you would obviously be able to start mixing with your fellow care home residents. But if you may be an individual what potentially could be on the shielding list, then obviously you will be you continue to obviously not mix with other individuals within that care home.
Thank you very much.
Thank you. Councillor Smage, would you like to ask your question?
Yes, thanks. Mine was on the vaccine. Is that okay to ask the question still?
Can we come back to that then, because it's questions to Jane.
Yes,
thank you. Warner, is your question to Jane?
It can be anyone. It's to do with the vaccine and the different types of vaccine and where they are. Okay.
Okay, so shall we come back to that then? If there's no further questions for Jane, then Jane is the meeting.
Yeah, thank you ever so much.
Discussion on the vaccine.
Thank you.
Yeah.
Thank you, Councillor Zaman. And I'm really grateful for the flexibility of the panel.
Yeah, thank you, Councillor Zaman. Have a good afternoon.
Thank you.
Okay, so where were we? Emily, Councillor Smade, do you want to ask your question to Emily?
Okay, thanks. I want to know about disinformation on the vaccinations and how if you're going to be looking at that locally and what.
Did you say disinformation, Councillor Smage?
I did.
Disinformation. Yeah.
And how you're combating that locally, please. And also I want to know about carers, because carers come into the next two priorities, don't they? And how are you identifying carers to be able to invite them to have their jabs? Thank you.
Okay, so if I take the question about the disinformation, and then perhaps if Carol, Lindsay, you can pick up the question about the carers. I think your question about disinformation is a really important one, Councillor Smage, because we know that there are particular communities that are being targeted by poor information. What we are trying to be very clear that we're doing is giving people good quality information so that they can make their decision based on accurate information. So we're working with various different community groups to get that good quality information out to them. What I'm really keen that we avoid doing is going out to try and combat every single myth that exists about COVID, because the evidence shows us that if we start to talk about the specific myths, we'll end up introducing that myth to some people who had never heard it in the first place. So if I was to say to the panel, don't think about a pink elephant, think about a blue elephant, you are now, despite the fact that I've told you twice to not think about either a pink or a blue elephant, you're now thinking about both of them. And so what we're trying to do in combating the myths is give the accurate and correct information rather than responding to all of the individual myths that are out in the population. We're trying to do that by engaging with people who are known and trusted with communities. So some of our GPs have been doing talking heads pieces. We're working on a programme to engage with faith leaders so that they can give the messages, particularly once they've had their vaccination, that they have been vaccinated, to encourage others to come forward. But it really is about those kind of trusted voices, giving those accurate messages of the vaccine is safe, the vaccine protects your health and well-being, and that everybody should take the opportunity when it's presented to them. Carol, do you want to pick up the carers question?
Yeah, sure, I can do it. So carers of people who are classed as clinically extremely vulnerable were able to get a vaccination at the same time as that group. I believe that's cohort 4. I might be wrong, but certainly in the top 4 cohorts. The other unpaid carers were classed in cohort 6, and we've had a discussion about this morning. One of the things about the vaccine programme is that things can change very quickly, and we have been having to adapt to things as we go along, and this is no difference. It's actually changed as I've been sitting here. So the position in relation to unpaid carers in cohort 6, a number of them will already be recorded as such in their general practice. So practices will be able to identify people who are unpaid carers and will invite them in under cohort 6 to have a vaccination in the way anybody else will be in that cohort. The guidance that came out at the weekend just gone also indicated that we should work with the third sector to identify other unpaid carers who are perhaps not recorded in their GP record for whatever reason. And we have started to do a piece of work working with carers counts in Kirklees to do that. However, literally, as I have been sitting here, it does look like there's a development happening in NHS England to enable a national offer to be made to other unpaid carers who are not registered with their GP, and there'll be more information coming out about that in the next few days, next week. So that potentially has superseded the need for us to do some local work on that, but that is now happening.
Thanks. We like to be current.
Oh, yeah, very much up to date. Yeah.
Thank you.
Is there anything further, Councillor Smage? Okay. Thank you. Councillor Leslie Warner, do you want to ask your question?
Yeah, thank you. I mean, it's partly picking up what Alison and others have raised. The dire thing that is social media and all the incredible things you have to read if you choose to go there, which I choose not to most of the time. But one of the things through more scientifically minded friends is there are some quite strong views about the different types of vaccine. I'm not, whatever those views are isn't what I was going to discuss. It was just a general question. Would I be right in saying that if you had strong views and wanted to not have the Pfizer, that you would be going to somewhere like Boots or a small place that has not got the facilities to store at -80 or whatever it is, or is that incorrect?
I'll maybe let Lindsay come in on this, but my understanding is there is a very, very small number of individuals who may be unsuitable for Pfizer due to potential history around allergic reactions, but they are a very, very small group. However, as a matter of routine, people are not offered a choice of vaccine. And that's no different to any other vaccine we get throughout our lives. You know, we get our flu vaccinations every year. They come from different suppliers. This is the first example I think I've ever seen in my career of people talking about the difference between vaccine manufacturers. It just never normally happens. But I think I'm right in saying that, Lindsay, in that there's no sort of choice other than if there are medical reasons for a very small proportion where they'd be more appropriate for the AstraZeneca. And I think in the very small number of young people who are vaccinated, it's the Pfizer one that's authorised for 16 to 18-year-olds. Is that correct?
Yeah, that's correct, Carol. So like you say, we don't routinely offer choice, but certain people will benefit more, or it's enabled for them to have it. It's like, say, 16 to 18-year-olds need to have the Pfizer vaccine. With regards to the different vaccine and the storage, in actual fact, the local PCN sites, and that applies nationally, do actually get a delivery of Pfizer and AstraZeneca. We don't actually get given a choice of how much we get of those. They're just sent from NHS England. And when the Pfizer actually arrives at those sites, it's not in its frozen state. It's already thawed. So that's been one of the difficulties that we've actually come across quite significantly, in the fact that it does have only 3 days stability once it arrives at the PCN sites, and it comes in a set amount, and you have to use that amount within the 3 days. So that has been something that obviously has been quite difficult to work around, but we have done that really, really efficiently, to be fair, to get patients in relatively short notice to get the delivered vaccines within the 3-day window for its stability.
Thank you. I mean, and just adding to what others have said, I mean, my cohort, late 60s, all my mates all got it last week. We all were comparing, what time yours, what time's yours? And without doubt, everybody was incredibly impressed with the speed, how quick it was, you know, and, you know, for most of us, barring a sore arm, it's been fine. So, you know, just brilliant.
That's great.
That's what happens when you give things to the NHS to deliver. No comment.
No, Leslie. Councillor Armour, welcome back. Are you willing to ask a question on this item, or I'm sorry that we lost you previously.
Well, I was going to ask a question on an item long ago now, because I've been wrestling with technical problems. But it was just about domiciliary care in the community, if you like. And historically, there's been many issues with timing of visits being to suit staff, not to suit the caree. So disabled people, some were working age disabled people, and they couldn't have a visit before, say, 10 o'clock in the morning, when they had to be helped up and to get dressed at 8 o'clock in the morning. Are we able to be a little bit more flexible at going forward, was the question.
Is that for the previous item? Yeah, I don't think.
Yeah, I'm not sure there's an officer left on the call that could answer that, Councillor Armour. But if you'd like me to take that question away to Richard and to Helen.
Richard Parry.
Oh, it's a good job I was being polite about him, isn't it? He's still here.
Councillor Armour, shall I just pick that one up?
Yeah.
Thanks, Councillor Armour. You're right. In the past, one of the risks was that we worked to a bit of a kind of time and task approach. Some of that was when the supply of home care was more constrained, and as you can imagine, there's kind of peaks and troughs in terms of demand for kind of home care. So particular points of the morning and evening when there's an awful lot of demand, and other times of the day when there's very little demand, and it was difficult to get the staffing to accommodate that. As we said earlier, we've significantly increased the availability of home care, but we're also moving to step out of the relationship between the home care provider and the individual who needs the care and support, and allow individuals to negotiate much more directly with the home care provider to build in flexibility, rather than having to come back through to the social worker to agree changes, in the time of a care package being delivered. So we hope all of those things will enable us to be more flexible.
Thank you, Richard. That sounds very promising. Thank you.
Super. Thank you.
Okay. Is there any further questions, Councillor Rama?
No, thank you. I'm afraid I've missed half the meeting for various IT reasons.
No worries. Okay. Is there any further questions on the COVID item? David?
Yeah, I just wanted to ask in relation to testing, both the national testing programme and the local testing being done through public health. Are there performance figures available for that?
Yes, there are, and Jane can share those if you want a particular item on it. Next time we come to talk to you, I'm sure we can give you a general overview of those figures.
Yeah, sorry, on the tracing, yeah.
On the tracing, sorry, I thought you said testing.
I think I gave the wrong word. I meant tracing, yes.
Yes, there is tracing as well. Yeah, we can do both.
Yeah. Thank you.
Okay. Any further questions?
I've been a little bit all over the place in terms of the ordering. Do you want me to do a brief overview of the figures and the data?
The data, yes. I was just going to come to that.
Okay, let me just share my screen again. Bear with me 1 second. Okay, so I'm just going to turn my camera off as well because my network's not coping particularly well at the moment. So I'll turn it back on when I've finished. So update of the position in Kirklees as things stand. These were the figures from yesterday. So we've had 184 cases in the last week, and the panel will be able to see from the graph that's presented here that we've seen a general kind of the waves as they've been described nationally, and then in the period of time since the third lockdown started, we've seen a steady decrease in the number of cases. So we're really pleased with the progress that has been made. We still have more cases in Kirklees than we would like to have, but the numbers have been very much going in the right direction. If we then compare to the weekly rates per 100,000 population, hang on, if I do that, it will make it slightly bigger for you. There you are. So this is a comparison across Kirklees and the are you still there? Hello? Yeah, you are still there, aren't you? I've just lost my connection for a second. The weekly rates per 100,000 population across West Yorkshire, you can see that the 5 West Yorkshire local authorities are very much in line with each other now. But the Kirklees rate is the third lowest in West Yorkshire at 183.95 and is now very similar to the England average, having had a period of time when we had a rate that was much lower than the England average. I think one of the important things to note is that as the numbers get smaller, the variations will get bigger because that's just what happens when you have a smaller number of cases. You see wavier lines, you see more variation in the data. But again, generally a good news story for the Kirklees population, but we need to keep going. We need to keep following those very basic messages. The panel last time asked some specific questions about the Kent variant. I think that was just starting to make itself felt in this country the last time I came to the panel. And I said I'd bring some figures back there. So you can see that over time, this data starts from the 5th of December, when it was a very, very small number of the samples that were tested that was showing to be the Kent variant, and that has increased over time. That's not particularly surprising that the Kent variant is more infectious. It doesn't appear to make you any more ill than the other variants, but it is more infectious. So it's in effect just winning the race because it's getting there first. I think it's really important that every time I come to talk to the panel, we give the messages, we give the data, but we really reflect and we give emphasis to the very basic messages that continue to be incredibly important. It feels like I've been coming to this panel for quite a long time now to tell people to wash their hands, to cover their face, to maintain 2 meters social distancing. Important that we reinforce those and that we continue to reinforce them through the vaccine rollout and beyond. We've talked a lot today on the panel around encouraging the flu vaccination. I'm really keen that people continue to take that offer as well. The panel have asked some really useful questions about ensuring that national messages are tailored locally. We need to take these messages into our communities in a way that suits them, working very hard to do that. Really encouraging the uptake of the vaccine and making sure that the information is out there very clearly about how and where you can access the vaccine. And I think the council, along with our NHS colleagues, have been working very hard on that and being impact and is where Jane started last time. So again, very grateful to the panel for tolerating the slightly out of order approach that we've taken to delivering that information, but hopefully that's covered the points you wanted covering. Happy to
thank you.
any questions.
Yeah, no worries. It doesn't matter what order we've got the information that we were looking for. Any questions for Emily on the data that she's presented? Well, they all seem to be happy with that. Well, thank you for that detailed information. And oh, David.
Oh, I thought I'd got away with it then.
Yeah, sorry, it was just to emphasise your key messages at the end there, Emily. I think the other key message is about tracing, which is why I raised the point before, and we don't get an awful lot of information about that. So, but I think that's a key part of the whole jigsaw.
Absolutely. None of the things that Jane's talked about or Carol's talked about or I've talked about, none of those things in isolation are the thing that will make the difference. This is about all the different elements, all of together, but being able to identify those being exposed and break that chain of infection is absolutely vital.
We lost that last bit, Emily.
Sorry, my network is I'm half term. I assume he's streaming something, so I apologise. I'll put something in the chat, Councillor, is okay?
That's fine. That's fine. Thank you.
I'm so sorry.
Any further comments, questions to Emily?
No,
Carol? Okay, well, in that case, I'd like to thank you, Emily, for attending and giving us that detailed information, and thank you for everything that you're doing. You're doing a superb job in terms of, with the pandemic and trying to get things under control and back to some sort of normality. If we could move on.
Thank you, Councillor Mann. I'm breaking up a little bit. I appreciate that. Thank you ever so much. I'll see you all again soon.
All right.
Bye-bye.
Bye-bye. And if we can move on to the next item, which is item 8, future configuration of the Kirklees clinical commissioning groups. Carol McKenna, if you want to start up on that information, that item. Can't hear you, you're on mute.
Oh, I've been doing so well. So I've got a couple of colleagues with me. Rachel Carter and Siobhan Jones are both here for this item as well, and we've got a few slides just to go through. I'm going to do the first few of them, and then I'll hand over to Rachel. And this feels a little bit like, when we just talked about the vaccine and I said that the world tended to move as around us. This has felt a little bit like that as well. So the specific item is to discuss the merger of the two Kirklees CCGs from the 1st of April. But clearly, since we took those decisions, there has been national change in NHS policy, and we're looking at further change. So I thought it'd be helpful just to say a little bit about that context first before handing over to Rachel to talk specifically about Kirklees. So just a few slides from me at the start then. So, okay, if I can just, are you driving them, Rachel, are you? Yeah, so the if you wouldn't mind just moving on to the next one, Rachel. The NHS white paper was published just a few days ago, last Thursday, following it, as you know, it had been leaked to the press the weekend before, called Integration and Innovation, working together to improve health and social care for all. And it sets out the direction of travel that has been discussed since before Christmas, when an NHS England board paper was published that gave some indication about the direction ahead. What the white paper has confirmed is that CCGs will be dissolved and responsibilities transferred into an integrated care system. You'll know about the ICS, you'll know ours, West Yorkshire and Harrogate. So the intention is that ICSs will become statutory bodies and take on the functions of CCGs, with CCGs being dissolved. And that should take place from the 1st of April next year, subject to legislation being passed. So clearly what that means for us as a Kirklees CCG coming into effect on the 1st of April is that we will operate for a year. That's what that means. So we had no sooner taken the decision to merge than the national policy change started to appear. So as I say, things have been moving at pace. If I can move to the next one, please. So as I've said, the proposals within the white paper are to establish an ICS NHS body. And really that's to drive greater integration within the NHS and increasingly move us away from discussions about commissioners and providers and that traditional split that's operated within the NHS. The intention is that within the ICS there would be two bodies, one of them called an ICS NHS body, the other called an ICS Health and Care Partnership. And the ICS NHS body would bring together NHS organisations, and their role would be to plan and secure services to meet the health needs of the population. But importantly for us, to also allow delegation into places, so into places like Kirklees and or provider collaboratives. So even though the functions of CCGs will go into this West Yorkshire body, some of that will be delegated back. In fact, quite a bit of that could be delegated back into us locally. The ICS will also have a health and care partnership, which is a wider body, bringing in local government and wider partners such as public health and third sector and others. That at the moment is quite similar to how we operate as a West Yorkshire ICS, where we do have a quarterly partnership board that brings in a whole wider range of partners. But actually the West Yorkshire and Harrogate ICS already operates in a way that is not just about the NHS. There are many partners there already. The local authority are a core part of it, as are the third sector and range of other organisations. So that is not too dissimilar from some of the principles that we've been working to already within our ICS. I'll just move on. Yep, and our ICS at the moment, as you know, it's not legally established. That will come from next year, but it has very much worked on the basis of primacy of place, and that principle is coming through into the conversation about what the new arrangements will be. So wherever possible, we want to be able to continue to work in a way that enables us to take decisions locally as close to the people they affect as we possibly can. And within the white paper, it sets out there is an expectation that place-based arrangements between local authorities and the NHS and other providers will be established. And they'll be at the core of the integration in the way we work locally. There'll be some elements of it that will remain set, but hopefully there will be large elements of it that are where we have flexibility and we can determine locally how we'd like that to look. And it does say that health and wellbeing boards will remain in place. I think it's probably important to mention at this stage that within Kirklees we already have a fairly well-developed Kirklees Integrated Health and Care Board, where we've got a range of partners again round that table. That's been meeting since last June. What we need to do now, and we're going to start to talk about next month, is what more do we need to do to develop that arrangement to help us meet the requirements of the white paper and work effectively within the West Yorkshire ICS. If we move on. There are some new duties coming our way as part of this as well, a duty to collaborate on NHS organisations and local authorities, and a real focus on what's described as a triple aim in relation to promoting individuals' health and wellbeing, ensuring quality of care and effective and efficient use of resources. So that's all set out in the paper. And some quite specific things to try and reduce some of the barriers to collaboration that feel to exist at the moment. So at the moment, as a CCG, we can form joint committees with other CCGs, but we can't form joint committees with other providers, for example. And the intention is to remove barriers like that and enable the new ICS to form joint committees with NHS providers, to enable different providers to form joint committees between them, and to have broader representation such as primary care networks, the local authorities and the community and voluntary sector. It'll also continue to strengthen this delegation that I've talked about into place and build on arrangements around pooled budgets, some of which we already have in place. It will allow more flexibility to create joint appointments as well. So we do have some joint appointments at the moment between like the CCG and the council, but it can become trickier to have joint appointments at senior level, for example, between CCGs at the moment, the ICS in future, and providers. So there's going to be some more flexibility around that as well. And if I can just move on. We're expecting some changes to the procurement rules as they affect the NHS. And at the moment, NHS England are consulting on a new provider selection regime that could be applied for the provision of clinical services. So just to be clear, this doesn't affect procuring things like equipment, but when we're talking about clinical services, the sense is that actually we spend too much time in competitive tendering processes where actually NHS bodies working with the local authority are far better placed to be able to determine what the right solution for us locally is without necessarily going through a full competitive process. So that does mark a bit of a change to the way that we have previously worked. And I think that might be my last one, possibly. Yes, so I'll maybe just hand over to Rachel to talk through the Kirklees CCG, and then we can pick up any questions in the round at the end.
Thanks, Carol. Hello, my name's Rachel Carter. So, as Carol said, we're now looking at the merger of the two Kirklees CCGs within the context that she's just described. We have been thinking about it since December 2018 when the NHS long-term plan was announced. But the final decision was made in November. So the plan is that the CCGs will merge and the new Kirklees CCG will be effective from the 1st of April this year. At that point, the existing CCGs will cease to exist, and everything from the existing CCGs, including staff and all of its property, its contracts and so on, will all transfer to the new CCG. It is purely an administrative change. There is no direct impact on patient-facing services, and for the reasons that Carol has set out, we are looking now at the existence of Kirklees CCG being of a limited duration, but we remain confident that that creation of Kirklees CCG is supportive of the direction of travel as we move towards the ICS from 12 months' time. We have recently undertaken a public engagement process, and the purpose of that, because we're not changing anything to do with public services, it's not a mandatory consultation process, but we did obviously recognise the importance of telling people about the merger and seeking views that we can now use to inform the development of the new organisation in terms of checking against inequalities around how we engage with people in the future and how really the culture and the look and feel of the new organisation. So I've just highlighted some of the key themes that have come from that engagement process. The vast majority of people we spoke to were supportive of creating a single Kirklees CCG. They felt it was a natural progression of the working arrangements of the two CCGs, that it would give us a stronger voice as Kirklees working within West Yorkshire, that it would help us with consistency of services across the full Kirklees population, rather than some of the differences that emerge for non-clinical reasons at the moment. It would help partnership working, and we've certainly heard that from some of our partners, that having a single Kirklees CCG to work with rather than the two existing CCGs will be helpful for them. And it will help us to make a better use of our resources so that we can focus absolutely on patient-facing services, rather than some of the administrative tasks that are necessarily duplicated because we're two statutory organisations at the moment. Some of the concerns that came through from the engagement, the main one, people were worried about a Kirklees CCG being Huddersfield centric. There were some comments that we would use the opportunity perhaps to level down to achieve equality and not seek to level everybody up. Comments about fairness with neighbouring areas. So because we share our acute hospitals with Calderdale and with Wakefield, people wanted to be assured that Kirklees wouldn't lose out. There were some suggestions that we might be reducing staff and local knowledge. As I said, all of our staff will be transferring to the new organisation. And people were clear that they didn't want a one-size-fits-all approach, that we need to continue to recognise the diversity of the Kirklees population and to respond to community and group needs rather than just trying to fit a universal approach. We did ask people specific questions around what they would need to see to feel that those concerns had been addressed. And some of the suggestions that came through were about visibility of us recognising differences across Kirklees, about making sure that we continue to hold meetings in venues across Kirklees once we can meet face to face again, and to make sure that we cover the agenda across the whole of Kirklees so that people don't feel that anything is being hidden from them. They felt it was important that we had representation from across Kirklees, and we put a lot of focus on that in developing our new governance structures to make sure that we have particular representation from each of the 9 PCN areas, to make sure that we can hear that strong voice from each of the communities, and that we make sure that we demonstrate we're investing to tackle health inequalities. Just briefly on the next step, so the new Kirklees CCG will be established from the 1st of April. We will clearly be continuing to reflect on the public feedback, and actually we're continuing to gather feedback through our Community Voices programme. That will give us the opportunity to hear particularly from some of the hard to reach groups, and we will reflect that in our equality impact assessment, in particular our comms and engagement strategy and the organisational development. And as Carol's touched on earlier, we will also use all of that and the strength and the power of the Kirklees voice to shape the West Yorkshire and Harrogate ICS and ensure how the role of Kirklees place sits within that proposed new structure. So, okay, I will stop sharing the presentation at that point. So I think that was the end of the sort of the formal information we'd had to share, Councillor. So I think we're sort of open to any questions or discussion that the panel would like to have.
Thank you. Dave, you have a question? You're on mute.
Thank you. Yes, the integrating care document that was attached as an appendix, really. There are an awful lot of questions arising out of that, but we did have a discussion in the pre-meeting about the possibility perhaps of a workshop to look at that in more detail rather than trying to consider the details now. So I won't ask any questions about that document, just a couple about the main proposal. Are there any specific costs involved in the merger? And secondly, as I understand it, the way in which services are commissioned across the 2 different parts of Kirklees at the moment do differ. So is there a plan to ensure that the commissioning over the next year is equitable across the whole of Kirklees? Thank you.
Do you want to take the point about cost, Rachel, and I'll pick up the second bit? I mean, there are some small technical costs, aren't there?
There are a small number of costs. So what we've been very clear on throughout is that the merger process must not in any way compromise our COVID response. So we're working very hard to make sure that people's focus continues to be on that. So in doing that, we brought in specific resource. So I'm here as a specific resource to support the merger process, to make sure that I can channel things and really make as little impact as elsewhere. But I'm very good value. So that's a minimal cost. Actually, broadly speaking, it will save costs across the 2 CCGs. Because it will allow us to do things once, and so that the specific things will save, like audit costs, for example. At the moment, because we're 2 separate organisations, we have to have 2 separate auditors, and we have 2 sets of annual reports and so on. So they're minimal because we have worked very hard over the last 2 years to to integrate across the two CCGs, but there are some specific things which more than sort of balance out those short-term additional costs just to get us through the merger process. We can't identify a specific number in terms of cost because things have been chopping and changing so much because of COVID resourcing.
Okay.
Thanks, Rachel. And on the point about differences in commissioning, that is one of the main drivers behind merging, was to try and get more consistency in how we commission and plan for the residents of Kirklees, so that there weren't differences that couldn't be justified, if that makes sense. So that was definitely one of the reasons we wanted to do it, and one of the reasons we still wanted to do it, even though we knew it was of limited time. There are a number of areas already where we commission services in a very consistent way. So for services such as mental health, we've worked together in partnership across the two CCGs actually for many years, and for some areas we've always worked as one, even though there are two CCGs. There are other areas where there are differences. So for example, for a whole variety of reasons, there are some differences in some of the services that might be delivered in general practice in Huddersfield compared with North Kirklees, and there might be different pathways into the different acute trusts that result in differences about what is then provided out of hospital. They're not massive, but there are some, and I think what we will seek to do in the year of the Kirklees CCG is where it is really important to smooth that out, to try and get consistency. The one sort of caveat I would give to that actually though is to say that having everything exactly the same across Kirklees, I do not believe is necessarily the right thing. I think one of the benefits of being a single CCG is it enables to understand the needs of the total population, but working with our PCNs, understand the specific needs of localities. And I think one of the things that COVID has really illustrated is the extent to which inequalities exist within our population. We knew before, obviously, but it's really brought that to the fore. And sometimes it might be appropriate to commission something for one area that you don't need to commission for another. So having completely identical services across Kirklees would not be the right answer. But I think we need to get into that and understanding it in a little bit more detail. I can't promise that we'll have gone through every single bit of difference by the time the Kirklees CCG comes to an end. That's the only thing I would just want to sort of mention at this point, because we do have a limited period of time.
Yes, I was using the word equitable in that broader sense that you were talking about, reflecting health inequalities rather than identical services.
Yeah.
Thank you.
Thank you. Can I bring in Lynn Keedy? Lynn,
thank you, Chair. I haven't a question as such, it's just a comment really, and it's that, having regard to the way in which the West Yorkshire and Harrogate Health and Care Partnership has already been working very effectively in a number of capacities, such as the suicide bereavement service, grief and loss service, the wellbeing check-in service, and also engaging with the primary care networks. We're certainly not going to be coming from a standing start when we go to the West Yorkshire and Harrogate ICS arrangement, and I just really wanted to say that I'm very hopeful, because we've got the advent of the primary care networks and all that's happening there, that this is going to be like one regional multidisciplinary team that is going to work collaboratively in partnership. So I'm really quite excited by it, and so I just wanted to share that. Thank you.
Thank you, Lynn. Councillor Bill Armour.
Yes, thank you. Carol's very gently brushed against this earlier. I'm wondering, are there any implications for the hospitals? Because to my mind, it would make sense to have a Kirklees NHS hospital trust rather than split between Mid Yorkshire and Calderdale. Is there any chance for us getting a proper Kirklees provision?
I think the way I'd come at that question is to say that the white paper talks a lot about provider collaboratives. So it points the way to having, say, acute trusts in West Yorkshire, and let's just use our two as an example, Mid Yorkshire and CHFT, working together in closer partnership than they will have done in the past. And sometimes the fact that we've, for many years in the NHS, been in a bit of a commissioner-provider split and a competitive type environment, that has not helped collaboration. And I think the intent behind this latest policy is to get the trust working together more closely. And I think for us in Kirklees, that can only be beneficial. I suspect some of the wider planning actually around what some of the more specialist acute services look like would be more appropriate to be done at a West Yorkshire level. And in fact, we already do that for some services such as stroke or vascular care. Quite a bit of the specialist cancer services are looked at on a bigger footprint. And I think with a bit more of that, what it helps us do is look at what the need is for populations rather than how the individual organisations are configured. Can I sit here and say it means there will be a Kirklees acute trust? No, I can't, because we're very far down the line of, you know, the reconfiguration of Mid Yorkshire has been implemented for several years. We're very far down the line with the CHFT one, but undoubtedly I think there will be much closer working between these trusts, which I think would be helpful to us in Kirklees where we have two.
Thank you.
Councillor Leslie Warner. Can I bring you on?
Yeah, thank you. Okay, just two questions really. It's the views you've sought. I mean, I've just noticed even when it came to the mergers of the hospitals, it's relatively few. It seems a relatively small number of people have completed a survey. So, I mean, whilst I suppose you could argue that most people aren't that aware of it, and that as long as they can get to their doctors, that's all they care about. But I'd always get a bit worried when I see consultation and then I look at the amount of people actually being consulted with, which always seems really small. And then the second thing is, unless it's me, can we clarify that we're going to have this new joint CCG for a period of a year, and then everything's going to change again if we look at the latest statements from the government, which obviously are worrying many of us in the light of, you know, the greatest pressure ever put on the NHS, new proposed changes. So it begs the question, is it worth going through this for the fact that you're in the end going to be non-existent and replaced by something else again? Or am I reading it wrong?
No, we did have that conversation back in December when the National Direction of Travel became apparent. We did actually say and have the discussion with NHS England, is it still worth us merging? So we gave it a bit of thought, and actually the view was, yes, it is. And I do completely take the point about, is it worth having one lot of disruption only to move straight into another change process? But we felt for a few reasons really it was still worth doing. I think one of them, I think Dave touched on earlier, the conversation about looking at things from a Kirklees perspective and thinking about how services are commissioned from a Kirklees perspective. That still feels like a good thing to be able to do. We felt that as a Kirklees CCG, we would be better placed to, with Kirklees partners, play into a conversation about how the future ICS might look, rather than if we were two separate organisations. And we also felt it was a logical step on the sort of journey towards a Kirklees place-based strengthened partnership, and almost making that sort of mental shift towards being Kirklees rather than being North Kirklees or Greater Huddersfield. So it's an absolutely valid question. We did think about it, but we thought it was still worth doing. But I do recognise it feels like it feels like a little bit like, yes, we are in transition for a longer period of time, but actually our staff have been working as a single team for several years now. So for them, it actually shouldn't, I think for them moving into the merged CCG really won't feel that different at all, because they have almost been working as if it were one for some time.
And presumably COVID accelerated that, in that you've needed to communicate more anyway.
Yeah, I think, you know, the question has been raised nationally, hasn't it, about why are these changes happening when the NHS is working through the pandemic? And I think the answers I've seen are that, first of all, some of these barriers to collaboration that we've seen have potentially sometimes got in the way in their emergency response to the pandemic. But also, we've demonstrated in response to the pandemic that we can work together in a different way than we did before, so we should harness that and make the most of it. And actually, there's never a good time for change. You know, the NHS is going to be recovering from the effects of the pandemic for several years, so there's not going to be a steady state for quite some time to come. So we might as well get on with it, I think, is the view.
Except that I suppose there's obviously reservations, like somewhere it was talking about, I can't refer to the place now, the clinical services, getting rid of the competitive process, which in turn rings alarm bells for me, because clearly a lot of stuff has gone on where there's been no tenders gone, and questionable where, you know, a lot of money went. I won't say any more than that, but you know, it kind of worries me if we're losing the ability to be completely transparent how and where everything is being delivered and who's bidding for what.
I don't think, well, I know the intention is not to go from having, you know, extreme competition to having nothing. There is a new provider selection regime that's being consulted on at the moment, and it does contain a number of different scenarios. So there will still need to be elements or processes around decisions for the awarding of contract. It's not to take that out of the system altogether. What it is intended to do is to try and remove the sort of bureaucracy that goes with competitive procurements where that is not going to bring any added value. Because sometimes we find in the NHS we're having to do competitive tendering for relatively small value contracts. That takes up a lot of time and effort to not necessarily get the best result in the end. So it's coming at it more from that angle, I think.
Can you not understand, though, that from the public's point of view, there's a real need for reassurance that, you know, we are not slowly but surely fragmenting the NHS even more, you know, because there is worry across the board that it's being broken up increasingly across the country.
I can, but equally, I think this is one where you can't do right for doing wrong. So I think a competitive environment in the public sector generates a lot of public concern as well, because they believe it paves the way for private companies to come in and deliver NHS services. Arguably, the move away from regular competition, competitive procurements, might mean that there are less opportunities for that to happen. So it's difficult, I think, no matter what way you do it, I think people have concerns, and what's important for us as a CCG is to make sure we're really transparent in whatever we do, and if we take a decision to go down a particular route, we have to do that in a way that's open and honest and transparent, and people understand why we're doing it.
Okay, thank you for that. But there is just, sorry, Chair, just one last thing. We all know that recently, you know, things have passed that enable, you know, everybody wants to be assured that the NHS is not open to trade agreements. And, you know, being of a suspicious nature, I worry about these proposed changes that can mean that, you know, it's more open to bits being traded all over the place, that, you know, we haven't closed the door on trading our parts of our NHS. And that is very worrying. I mean, I know that's not for here, but it's at the back of my mind when I hear anything about change.
Thank you, Leslie, for your comments.
Sorry, Councillor, would you like to say a word about the survey in response to Councillor Warner's questions?
Yeah.
So it was just really to recognise, I think, Claire, you're absolutely right. It's an ongoing challenge, I think, to engage with the public in terms of the administrative side of the NHS and CCGs, and trying to do that in the middle of a pandemic over Christmas is not what you would plan to do. So we did recognise that, and the engagement period was extended from the 6 weeks that it would normally be. You're right, we only had 51 people completing the survey. I think the assurance that I would offer is some of the conversations that we had with representative organisations who clearly represent bigger groups of people within the community were really good and helpful conversations, and perhaps you can see that from some of the concerns and views that were expressed, that they were informed, rich discussions about the nature of the changes from people who perhaps are more involved and more interested in the administrative side. So I think we absolutely recognise the concerns that you've expressed. The views that we had back were consistent from the different groups and the discussions and the surveys. So we do take a level of comfort from that, and we are continuing to have conversations where we can gather further feedback. So we're leaving effectively the engagement report open. We've produced an interim report, and then we will continue to gather the feedback, but absolutely sort of recognise the concerns that you've raised.
Thank you.
Thank you, Rachel, for that. Councillor Smage.
Yes, thank you. Thank you. Can I ask about the white paper talks about alignment within an integrated system? And I mean, we know that you talked about the Kirklees as a place, and this joining the CCG, having a stronger voice. But we do know that there is not always alignment of Kirklees as a place in assumptions that are made to health provision for the needs of our whole population. And so what I'm wanting to know is, has there been any discussions other than CCG alignments to help with Kirklees as a place and the Kirklees health needs being taken more into account when changes to health provision are being discussed?
So I think some of this I maybe touched on in the answer that I gave earlier about obviously the focus being on more provider collaboration. And I know certainly there is a regular dialogue between the acute trusts, both in West Yorkshire and in Kirklees, but I think it would be best to receive an update from them about that rather than me. I do think we've come quite a way in Kirklees in that within our integration board we have both acute trusts there, and they are both regular attenders at senior level. So they're playing in and engaging in a discussion about Kirklees and its health needs. And certainly we've had quite active involvement from the acute colleagues on topics such as health inequalities in Kirklees. So I felt a real shift in terms of, if you like, the sort of engagement and ownership for the sort of Kirklees place from our acute colleagues, for example. I see a question in the chat. You raised the thing about is this something that'd be helpful to discuss in the workshop, and I really think it would. But I would suggest it would be really valuable to have provider colleagues in that conversation rather than me attempting to speak for them and misrepresenting them, really, because I know sometimes we've said that up until now the focus on the white paper's often been very much about the abolition of CCGs. But the impact of the provider collaborative element, I think, and I've certainly heard Owen Williams saying this, I'm sure he wouldn't mind me repeating it, that is significant, and we do need to understand more about it. And I think a workshop that focuses on the breadth of the white paper, not just the CCG element, could be quite valuable to get underneath some of that.
Okay, thank you.
Just a comment on some of the concerns that are highlighted on page 36. I must say that, you know, particularly on the how to provide assurance to communities, I think there should be a stronger focus so that particularly the inequalities agenda and that gap isn't widened by, you know, the actions that the CCG are taking, and particularly, you know, due to the pandemic, as we're already hearing that the equality gap is getting wider. We need to ensure that, you know, the voices of those communities are heard within your agendas, and ensure that, you know, we are meeting their needs, so that, you know, just because you've moved to Huddersfield and you know, the focus is not on North Kirklees anymore. Is there any further comments or questions on that paper?
May I just make a comment on that, Councillor Mann? I think it would be really helpful. What we're trying to emphasise is we haven't moved to Huddersfield. We are a representative Kirklees organisation that happens to have a hub building in Huddersfield. So I think really, if we just ask all colleagues if we can all sort of share in that message, we are absolutely focused on the whole of Kirklees. We will continue to make sure we're visible across the whole of Kirklees, both in terms of how we operate as an organisation, but in terms of our public facing activity. But this is absolutely not about a shift or a takeover. This is about us being a genuinely Kirklees focused organisation.
I totally agree with that, Rachel. Sorry, I wasn't sure if I picked up that point right there. Like you say, we haven't moved to Huddersfield and forgotten all about the wider patch. And actually, for the last 9 months, we've all been working remotely anyway. So it just shows it doesn't actually matter where you are. We're perfectly capable of serving the entirety of the population. And that is one thing I think we can demonstrate by having had to work in this strange way for the last 9 months, that we can do that and we can respond in that way. It's not about where your office happens to be based.
It was comments and concerns that, as part of your survey that had been picked up.
Yeah.
Okay, if there's nothing more to add to that, I'd like to thank you for attending and giving us very sort of detailed information on that, and acknowledge that the reports that have been presented before us. And the only sort of recommendation that I've got on that is that we move with planning the workshop, and I suppose we'll be in touch outside of this meeting to ensure that that's planned, and members of the panel get a detailed understanding of the integrated care systems. Is that okay?
Thank you.
Thank you very much for attending.
Bye. Bye.
And if we can move on to the next item, which is the work programme for 2021. Richard, do you want to come in with that item?
Yeah, thank you, Councillor Zaman. Yeah, basically this is obviously a standing item on the panel agenda. We've obviously, as you said at the pre-meeting, now this is our last scheduled meeting for the municipal year. I think, as we discussed in the workshop in January, it's clear that the impact of the way that we're working currently, particularly in relation to the lower levels of activity in terms of the formal meetings, has meant that there's many issues on this work programme that unfortunately we haven't been able to cover maybe to the detail that we would have liked. However, on the basis of some of the discussions that we did talk about at the workshop, I think the move to maybe sort of having a work programme that works around themes as opposed to specific issues, I think will help. So my proposal following from that workshop would be to start developing that as a forward work programme. So obviously with the permission of panel, that would be my next goal, would be to develop a work programme working around the themes that we touched upon at that workshop discussion, which we can obviously we can present, or I can present to you. And my next question would be whether you as a panel feel there are any issues or any areas that you would wish to investigate further before the end of this municipal year, which we can do by either looking to see if we've got the capacity to add an additional formal meeting into the agenda, or through some kind of workshop if it's felt more appropriate. So I think at the moment that's all I'd have to say, Councillor Zaman.
Mm-hmm. If members want to come in and comment on whether that you think that is the right way to move forward, I mean I know we did have a workshop last month, but if you're okay with the discussions that have already taken place, I'm happy to work with Richard and move on that and ensure that we get a plan, a programme sort of put together for the next municipal year. Dave, would you like to come in?
Yeah, I just wondered, following Richard's comments, whether it be worthwhile having a workshop session to plan next year's programme, bearing in mind the points that we agreed on at the last workshop session. So to actually put that into practice, to implement it, might perhaps be helpful. I appreciate we do have quite a bit on, but might be worth considering.
Do you want to come in on that, Richard?
Yeah, I don't have a particular issue with that. I'm quite happy to put together a draft based on the discussion we've already had. I can discuss that with you, Councillor Zaman, and then I'm more than happy if the panel members wish to then discuss that in more detail at a workshop. Obviously, just to make sure that it covers all the key points. I would say that I think what we would normally do in any case is have what I call an end of year review of the work programme. We partly did that at the workshop in January, so we could do that. We could sort of formalise that obviously in the next session, and then when we move into the new municipal year. We would normally as well invite partners, cabinet members and officers within the council to also contribute to the formulation of that work programme. But I think as a starting point, I think we've already got quite a lot on the work programme. We've already identified quite a number of themes that we know that we want to take forward. So I think if the starting point is to have that as an agreed starting point at a future workshop session this year, then that's fine. I'm more than happy to do that.
Absolutely, thank you. Leslie, are you wanting to come in?
Caught myself. Yeah, just really what you're already saying. I just think in the light of COVID, and in particular the ongoing concern about well-being, mental health, suicide prevention, I think they kind of, really do need addressing. And is enough funding going that way? Because we all know just from the work in our own wards and how we spend the mental health, we could spend that money 5 times over easily. And I just would like to really flag that up. And also, I've had a number of people contact me regarding the ambulance, the ongoing stuff with the ambulances, because I know the proposed merger that's going ahead, that the whole thing with travelling is still a big hot potato, and it doesn't seem to go away, and then nobody seems to have an answer really.
We've got them as part of the work programme, and they've been this previous year to give us an update. But yeah, we can continue pursuing them.
Yeah, I mean, one of the things, if you want to, is obviously we can, aside of actually having discussions at the formal meetings or even the workshop sessions, where there are particular issues, such as, for example, issues around response times, which I think that's what you're alluding to, Leslie, isn't it, in terms of the Yorkshire Ambulance Service. And in fact, I think Councillor Armour also raised that at the workshop session as well. I'm quite happy to write on behalf of the panel to the Yorkshire Ambulance Service and get some, updated information around the response time. So at least you can get some written information as to where things stand. And if you then feel that you want to interrogate that further, then we can obviously look to do that. But at the very least, you'd have some up-to-date data, which will help inform your thinking about it.
Yeah, that would be good. Thank you.
It might be useful to try and get them to attend a panel meeting as well, really, because we do have that difficulty with them, don't we?
Yeah, I'm happy. Again, I'm happy to do that. I mean, as I say, I think once we've formulated the work programme around the themes that we discussed, I'll certainly in the interim period, obviously, contact Yaz to request an update in terms of data for response times across Kirklees. We can start thinking about, under those themes, who do we actually want to come to future panel meetings, and obviously if there's a theme that specifically around the issues to do with the ambulance service, then obviously we can include them.
Okay, thank you.
Yeah, can I just add on to that? That's that whole business of we mentioned at that meeting that the public, we don't get deputations and things, but that's often, I suspect, because people don't know that they're able to. And I think there is an issue about communication with the public, however that is done, whether more in advance, not least on the council website, or through community surgeries, that lets people know. I mean, there's so much that, I mean, I didn't know before I got involved with Scrutiny what was involved, and I just think it's important that we encourage more public awareness, and that they have the right, as happened earlier at the beginning of our meeting, to come and ask a question. I think that would be really, it would make us more democratic and more transparent, and I think that would be good.
Yeah, I mean that's not just an issue, I think, for this panel. I think it's a wider issue, isn't it, across Scrutiny as a whole. So I think that is an area that we can look at to see what initiatives we can introduce to actually help promote the work of Scrutiny and encourage public participation. We certainly in the past used to have a dedicated web page for Scrutiny, which we encouraged members of the public, if they had any issues or wanted to engage with Scrutiny, they could do it. That was one way. I'm not saying that was the only way, but that certainly was one way of doing it. But unfortunately, I think over time, with the pressure on resources and capacity, that's something that has obviously been put to one side. But I think we've got an opportunity, haven't we, through things like social media outlets and other communication channels to promote the work of Scrutiny. So I think you're right. We need to have a consistent approach across Scrutiny to encourage that participation, that public participation. So I fully agree.
Thank you. Dave, are you wanting to come back in?
Yes, please. Yeah, I appreciate we do have a lot on the agenda, but I wanted to suggest consideration of an additional topic to look at, and that is the health risks from toxic air. There was quite a big report or article in the Yorkshire Post last week about this, which focused mainly on the problem as far as older people are concerned, but it's a broader problem than that, and it really is quite significant. There's been some research by Asthma UK and the British Lung Foundation, and that's put a lot of detail into the report, which illustrates how big a problem this is. So, as I say, I appreciate we have got a lot on our plate, but maybe it's something we could begin to look at.
Okay.
I've noted it.
Yeah, can I just support that as well, if you don't mind me saying so? Because when I moved to Hebden years ago, and I did ask the doctors, I was someone who was an asthmatic and it had gone, and I come back to Hebden Bridge, and within weeks my asthma comes back. And I did ask the doctor about clusters, and there definitely are clusters in parts of the country. It's not public knowledge, but I think awareness and what preventative measures can be done would be really helpful.
Yeah, I've noted that. I've noted that, Councillor Zaman.
Oh, thank you for that. Any further comments? Okay, if we don't have any further comments, we come to the end of our agenda for this afternoon, and I'd like to thank all the panel members for your valuable contributions to the panel this afternoon, and I look forward to seeing you soon when Richard gets something in the diary.
Yeah.
In real time, even.
Thank you very much.
Okay, thank you.
Thank you.
Thank you very much.
Thank you, everybody.
Bye.
Bye-bye.
Bye.
Bye.